Well, thank you, Basil, and thank you, Alison, and the AIMS team, and all of you that worked so hard over the last, I don't know, it's at least a year, maybe years. Welcome to Sheffield, and it's a delight to tell you a little bit more about the StarMS trial, which is the trial that we've been leading from Sheffield for the UK, supported by the National Institute for Health Research, and I'm just going to mention a few things by means of background. Basil's been through this slide, and we've mentioned that the concept isn't new of treating MS with HSCT. It's 4 decades old. You might think, why has it taken so long to crystallise into routine practice? We're sort of on the brink of it, I think, in some departments, in some countries of the world. So animal models, Richard and others worked in the animal models to build the concept as long ago as the 1990s or 1980s probably. Human cases that paved the way, patients with leukemia and aplastic anemia who also had an autoimmune disease. And then in 1995, the first patients were treated in Thessalonica and in Chicago. Richard was amongst those people that treated people specifically for MS with an autologous transplant. And the EBMT has had a big role in building the field through its registry and its guidelines, which I've been very fortunate to be part of. And you can see how the rise in patients treated in Europe happened really over the last 10 years since increasing evidence came through and recognition in the neurological communities that there was something in this. It dipped a bit in the pandemic, as we can all understand, but it's rising again. And it's been supported by these guidelines led by EBMT and Basil and other key people in the field. And it's now very much part of routine transplant practice recommendations within the EBMT. MS is there as a standard of care indication by the EBMT classification if it's in the highly active, relapsing, remitting group, for which there are randomized controlled trials. So I'm not going to talk about the MISS study, but I think this was a game changer that we were in Sheffield lucky to take part in, and led by Richard, and I think it's really turned the corner in the field in the last several years. And MISS, of course, it's now a sort of historical trial in that it proved the principle convincingly, but it was a comparison of transplant with a slightly earlier era of MS treatments, the things like interferon, glutaramine acetate, dimethyl fumarate, natalizumab, fingolimod. They were the comparator arm. But since then, the field's, like every field in medicine, it's continued to move. And you now have these newer, highly active agents, the ocrelizumab, the alemtuzumab, ofatumumab. Many of these things are used elsewhere in hematological practice, indeed, and cladribine, likewise. They are the modern ways of treating MS. They're proven to be very efficacious to an extent, and then the question is whether they're equivalent or whether HSCT is better, or whether HSCT is more risky, what is the relative benefit and risk of HSCT over the current standard of care disease-modifying treatment. So that's really something that the StarMS trial, along with a few other trials around the world, Beat MS, and RAM MS in Scandinavia, NET MS in Italy. There's a handful of trials that are ongoing that have come through the pandemic, that were sort of set up before the pandemic, got hampered in a big way, but I think we're all coming through. We've managed to kind of rekindle what was there, and hopefully these trials will report in the next several years, because it's going to take a bit of follow-up of all patients to get meaningful results. So this is a StarMS trial. It started out in January 2019 but really we were all due to recruit the first patients in around March 2020, which is, we all know what happened then. So we had to keep the flame burning. It originally started out aiming for 198 participants in 19 UK centres. And we've had to revise some of those estimates. I'm not going to go into great detail about that, but we would hope to finish the trial with a lower number sometime next year in terms of recruitment. But of course, there'll have to be 2 years of post-randomisation follow-up. Some of these slides are quite detailed, and they're going to be there for reference and discussion, and I want to leave enough time for discussion. But the aims of the trial are to determine whether HSCT has a superior clinical efficacy to the DMTs, alemtuzumab, ocrelizumab, ofatumumab, or cladribine, and importantly, an acceptable safety profile, because I live with risk day to day in the transplant and haematology departments. We have to make measured decisions on benefits and risks in a lot of cancer patients. I think the neurology community are more cautious, and it's a different mindset, perhaps understandably, but we do need to address the safety profile of the transplant versus its long-term benefits, and that's why it's important to do clinical trials to advance our understanding of how much better, or whether it's equivalent or even worse, HSCT is compared with standard of care treatments. And we also want to understand the mechanisms by which HSCT works, because that's going to tell us how to improve it. It's also going to tell us a little bit about MS, perhaps, its pathogenesis, its etiology, how we can use that knowledge to improve outcomes or even prevent MS. So all these mechanistic studies are useful, hopefully in time. So these are the primary outcomes. The NEDA is the primary outcome at 2 years post-randomization. You've got all these secondary outcomes which are about safety and surrogate clinical outcomes, and importantly, quality of life data is being collected. And they're measured at all these multiple time points. I mean, thank you to the patients for taking part so far in our trial, because they're going to have not just the potential hospital admission, but all these extra time points where they're going to have to be seen and assessed and blood taken and scanned and so on. So we don't underestimate the big commitment that patients put in towards contributing to a clinical trial like StarMS. These are the eligibility criteria. They've been modified over the years to accommodate neurological practice, age 16 to 55, diagnosis of MS justified by conventional criteria, EDSS score 0 to 6, relapsing remitting MS with one or more protocol-defined relapses or evidence of MRI disease activity in the last 12 months, despite being on a disease-modifying treatment, or rapidly evolving severe MS in treatment-naive patients. And then there's other exclusion criteria. As a haematologist, the exclusion criteria are probably the big thing, because you don't want people that are unfit for transplant, potentially. You don't want to take risks in patients with comorbidities. There's an extensive screening, randomization, and then treatment process. I won't go into everything, but it's all there in the protocol. So some of you may have even taken part in the study, but it's very thorough. And then the trial treatments are, of course, the transplant arm. The transplant arm is essentially identical to the MIST study with cyclophosphamide and cyclophosphamide and ATG, and with the priming cyclophosphamide being the same as in the MIST study as well. The stem cells are infused, and then there's follow-up visits where patients stay under haematology. They're screened for viruses that can reactivate in the post-transplant period. And then you've got these 4 disease-modifying treatments that you'll be familiar with that are really the standard of care in this high-risk group of MS patients. And then there's these optional sub-studies, mechanistic, as I've mentioned. Professor Paolo Moraro is in charge of that aspect. And then there's other important things, neuropsychology, the impact on neuropsychology. And then there's OCT, which are some novel neurological-based techniques comparing retinal nerve fiber layers, ganglion cell layers, microcystic macular edema, and thickening of the retinal inner nuclear layer as markers of neuronal injury, axonal damage and inflammation between the two arms. I read that as a true hematologist, so you'll get some experts telling you about that sort of thing in due course. But we've got the state-of-the-art sub-studies, and we hope that most patients will have taken part in those. So the recruitment to date, it's been challenging recruiting through and sort of in the aftermath of the pandemic. We've recruited 57 patients, there's 71 consented, and there's some that have failed the screening. But most patients that have put themselves forward have been accepted onto the trial. We're aiming for a lesser number, as I've said, for pragmatic reasons, based on statistical re-evaluation, and we do hope to finish the trial in the first part of next year in terms of recruitment, and then we would hope to report the trial subsequently down the line. So, I'm not going to go into each centre that's open. There are some big centres open, the London, King's and Imperial, Barts, UCL, the Sheffield. There's other centres that are opening in Scotland and or are open in Scotland and around the regional zones of the country. And we're having one big last push to get those open, and some of those centres may be near you. It's much better to have a transplant close to home than be travelling if that is feasible. So, in conclusion, I've been very fortunate to be in a cross-fertilisation of specialties. This has happened because people talk to each other between the specialties and get on and collaborate. I think there's as much to that sort of advance in medicine as there is in discovering something really clever and basic scientific and generating very novel drugs and other discoveries. I think if specialties can just talk and come together, then you often achieve the magic to move forward in medicine. So, this is something we said in 1996, treating autoimmune diseases is by destroying and then selectively rebuilding the hematopoietic and immune systems may not only produce clinical benefits, which we all want, but it may provide some important insights into the pathogenesis of autoimmune diseases. So hopefully one day there will be some very, very specific, highly effective treatments for MS, but this is part of the journey to getting there. Basil's shown this slide just to tell you about Sheffield, and I'll leave this slide up just so that you can take note of the StarMS contact details, the team that are so important in supporting this trial, and thanking the key people in the trial management group, the trial steering committee, the drug monitoring and safety committee members, and the site PIs and the teams, and of course the patients that are taking part in the trial. Thank you.
I just wanted to ask you about the safety profile comment that you made. So I find that interesting from the point of view as a patient, that's what I am, and also as a physio. So most of the people that I've seen who have gone for with an interest in HSCT have then seen the neurologists, who are the people who give them the information on the safety profile of it. And my question is really how we as a group can improve how neurologists might present the safety profile, because it's not the neurologists who are really the people who can give patients that information, is it?
Yeah, well, it's true. We all start out in medical school or in our clinical trainings, and we're all very general and knowledgeable. And I did neurology when I was a junior doctor. Other neurologists did hematology and maybe some transplant as a junior doctor. And things were very different 30 or more years ago. And then sometimes some of the leaders in neurology, I sense, just have those images what they went through, those overnight shifts they did in the 1980s, when things were very different. I mean, I can't say that the transplant is free of significant side effects. It involves a lengthy inpatient stay, but the specialty has evolved, and autologous transplant, and I'm talking about patients with myeloma and lymphoma. If you look at the national data and most centre data, there is a treatment-related mortality undoubtedly in that group of patients, but some of them are in the 70s, and it's around about 1%. And patients just go routinely through the myeloma treatment pathway, lymphoma treatment pathway. Nobody really sort of thinks too heavily about it, because the rewards of a deeper and longer remission, potentially cure, are far outweigh the risks and the relatively short-term side effects that people get. Undoubtedly they get them, but hopefully within a few months or so they're over most of them. So that's the kind of risk-benefit equation we've got to sell to the neurological community. And there are risks. I think the risks in well-chosen MS patients should be very, very low, much lower than we see in hemato-oncology. If you choose the right patient, the younger, the risks of their disability in those sorts of patients are massive. The implications of the recurrent inflammation in the brain and spinal cord are massive. It's massively disabling, all sorts of impact, potentially life-shortening as well. So it's about the balance of the risks and benefits, and we need to sell that to the broader neurological community that it's not a simple equation, but it's one that convincingly results in better long-term outcomes. And we hope to do this through the trials and other large number data that comes through from the registries, from the big centres. And I think that's coming through now at last, but originally I think that the neurology community were very, very conservative and weren't really prepared for this sort of approach.
Thank you, John.
Thank you.